Okay, let's get started. Okay, we have a case.
Yeah, what's the title?
Well, I don't know. If you didn't see it, you missed it officially. Like you could download the app and rewatch the rounds and take a look at the beautiful title page that I already passed, right? Okay, 35-year-old female with. Carol's gonna start throwing stuff at me. 35-year-old female with hip pain for 2 years. Worse with sitting. Where do we go from here? Let's say, I love the mailbox example, sorry to resurrect it, but let's say this is your neighbor. The reason I love the mailbox example is because you can't order an x-ray, an MRI, a CT, you can't get advanced imaging, you can't do a diagnostic injection. So this is your neighbor and you're at the mailbox and you are trying to differentiate. These are all kind of common, maybe a little bit small for you to read, but all kind of common hip problems. This is not an exhaustive list. This is just a basic list. There's an exhaustive list and it doesn't fit onto one page. So how are you going to go about differentiating your neighbor's cause of pain at the mailbox? What questions you got? Yeah.
The first one, the image was show me where it hurts.
Yeah.
She's got the classic C-center.
Yeah. So back here, yeah, kind of the classics.
Right here.
Yeah, where does it hurt is an awesome start. Hip pain pathology tends to be differentiated by location because the anterior causes are different than the lateral and posterior causes. Scott?
I was just going to say, Robert brings up a good point because sometimes patients say my hip hurts and they point at their SI joint or
Yeah.
it's not their true hip joint.
Yeah, we have that about 3 times a week. It's like, go downstairs. Okay. Anyone else? What questions are we asking to kind of help differentiate? Yeah.
Aggravating factors.
Yeah.
Actually, what makes it hurt?
Yeah. So for her, sitting is one. She says it's also worse with activity. She says, she's active, she's fit. She says when she does squats, kind of that bending hurts. What else? What other questions do you have?
History, what has she tried so far?
Yeah, great question. So hasn't really tried anything so far, but that kind of helps not only differentiate what the cause might be, right, but also helps differentiate, where are we taking this patient? Because it's a hip pain for 2 years that they've had multiple injections and have done 8 months of physical therapy is probably going to be approached different than someone who's just started. Yeah, any other questions?
She's had pain for 2 years. Why is she stalking you at the mailbox today?
Yeah. Well, it's because my wife usually goes to the mailbox and she sent me out there because she doesn't feel the best. And so she probably just catching me now. No, she feels like it's gotten progressively worse. So pain, kind of comes and goes. And when it flares up, she kind of modifies her activities a little bit and it goes away. But this time she feels like she can't get it to go away.
Is it radiating?
Yeah, great question.
Does it rule out? No.
Yeah. Sometimes you have pain that'll start in the front and goes all the way down to the foot and causes numbness on the bottom of the foot or the inside of the foot or leg, and that's kind of maybe approached differently than, no, it doesn't radiate, it's true kind of anterior groin pain. Yeah.
Describe the pain, like is it deep, does it feel more shallow, is it achy, sharp, shooting?
Yeah, great question. So a lot of the, this in general, some of the burning can be associated with neurologic pain of maybe like a radicular pain. Hip impingement, which is the title slide, tends to be like pretty sharp at times with like dull achy in the front of the hip and can catch. Like they feel like it's like stuck and it can like catch. Yeah. Any other things? Yeah.
Just to add on what Ash just said, is there like any specific movements other than sitting? Can they reproduce that click or catch?
Yeah, and feels like, like when she can't put her leg out, she feels a little bit stiff when she puts her leg out or sore, and then any sort of flexion at all. So yeah, good questions. Yeah, Chris.
Does anything alleviate it? What do you do when it hurts? Is doing a certain stretch or something help better?
Yeah, so she would say straightening her leg alleviates it. That's a great question. Ibuprofen or, one of the anti-inflammatories tends to help. Ice tends to help a little bit. Massage, like deep massage, because everything in the front of the hip is a hip flexor problem. That's a joke. Okay. Anyone else? Did I see a hand up in the back over there? Okay, so feel like we have a pretty good idea. How do you differentiate? Let's say in our diagnosis we have kind of anterior causes. How do we differentiate the different types? So let's go to the anterior causes here. How are we differentiating musculoskeletal from, like a skiffy, from, AVN of the hip? How are we differentiating these different types? Yeah.
Some of those are differentiated just based on the age of the patient.
Sure. Yeah.
Granted, 32 is like maybe not a skiffy.
Yeah, probably not, but could be like a unrecognized, like small skiffy and continuing. Yeah, absolutely.
Leftover, have they had this always kind of thing?
Yeah, 100%. Hopefully our history starts to eliminate some of these as we go along. She's pretty healthy medical problem-wise. So yeah, as we kind of narrow down, we start to compile more and more information, and we start to say, hey, some of these are more or less likely. So what are we going to do for this patient? So she's like, friend, doc, PT, chiropractor. What are we going to do if she's your neighbor at this point? You feel like you've gotten a thorough history. What's the plan?
Standing x-rays.
Yeah, so great. Pretty tough to do a physical exam at the mailbox. That causes concern with the other neighbors, but yeah. So get her into the office, get some x-ray imaging ordered on her way to the office. Absolutely. So this is kind of our standard AP, right? And there's a lot that we can tell or learn from an AP radiograph. So first of all, some of the things that I look for on whether or not, if we have a good AP, then a lot of the measurements we make, and our MSK radiologist here will back me up on this, if we have a good AP hip, a lot of the measurements that we make in terms of like the inclination and all that, which I'm going to get into a little bit today, are pretty reliable. If it's not a great AP, then they're not quite as reliable. So one of the first things I look for is the obturator foramen here pretty symmetric both sides? And if you're taking kind of a straight-on view with the x-ray being tilted the way that it's supposed to, the obturator foramen will look symmetric on both sides. The other thing you look for is the distance between the tip of the coccyx and the top of the pubic symphysis. Depending on male, female, that should be kind of between 1 and 3 centimeters. If you have the tip of the coccyx all the way up here and the pubic symphysis all the way out here, you're getting more of a view like down into the pelvis, and vice versa. If it's kind of, there's not really too much of a difference, you're getting more of a flat view with the pubic symphysis kind of shooting too far up at it. So those are the first couple of things that I look for, just to say, hey, do we have a good AP or do we not have a good AP? All right, anyone notice anything here on this x-ray?
Looks suspicious for acetabular overcoverage on that.
Yeah, on which, yeah. Yeah, and actually this is from a different patient, but here, yeah, 100% I agree. And what is how are you gauging that? Well, here you're probably eyeballing it, but
here, but typically you're looking for an angle where you're drawing basically a target on the femoral head, and then I use the lateral center edge angle exactly where we do a horizontal through the ischial tuberosities and look for an angle 20 degrees. Some people say 20 to 25 is borderline.
Yeah, good. Yeah, so this is kind of, they have a feature now where you can draw a line and then they can just convert it to a line. So it looks like I drew a straight line. I did not. So you have to have, when you're measuring inclination or center edge, so I would say when we are thinking about hip pathology, specifically if we're thinking about FAI or a labrum tear, which is I think where this is going, allegedly, you have to have a reference point base off the pelvis. So you can use the ischial tuberosity. You can also use the teardrop, but we have to set a 0 line. Sometimes you'll see an x-ray image and it's a little bit tilted from the bottom of the page. So we can't just use the bottom of the screen as our 0 line. So we set with like a Cobb angle measurement, a 0 line here, and then like you were saying, we get a center edge angle, and so we make a vertical line 90 degrees from our reference line, and then we draw a second line out to the edge of the sore seal or the socket, and that's where we get our center edge angle. And the cutoffs, less than 15, we're worried about frank dysplasia. Kind of 15 to 25-ish, we're worried about borderline getting into frank dysplasia. Kind of 25 to 35 is normal, and then over 35, we're calling like an overcoverage. So we didn't necessarily measure it here, but there's a lot of extra coverage here. Yeah, awesome. So our standard radiographs for hip impingement are AP, standing AP pelvis. Now, why standing? Why are we getting a standing AP?
See the hip when it's loaded.
Yeah, absolutely. What did you say? You said something?
Oh, I just like weight bearing, yeah.
Yeah. So a lot of our patients with FAI, we kind of get two groups, kind of the young, active. It's a problem associated with a labral tear, but also we get some of the kind of 30s, 40s, and older that there's a little bit more degenerative change of the hip, and how much arthritis there is or how much narrowing we see on a standing AP view determines kind of where the treatment's going to go. Certainly if we see a bunch of collapse and like significant early arthritis, that portends a worse outcome with a scope, and then we're doing pain management strategies or injections to try to get relief before maybe a hip replacement. But yeah, so these are the standard x-rays that we get every time with a patient that we're concerned about hip impingement. So standing AP pelvis, standing AP the hip, and then this is a false profile view, which kind of shows this anterior coverage there. I just have a little graphic here because I think when I show this image, I think some people have a hard time visualizing how we get this image, and it's standing with the patient at a certain position to the wall, and taking the x-ray this way. And you'll be surprised. Sometimes you'll see kind of normal from the AP in terms of coverage, but you get into this view and they're more narrowed on their anterior wall, or that they have good coverage on the AP hip, but they don't have great coverage on the false profile view. And then this is a modified done lateral view. So instead of kind of the true like frog or 90 degree, it's the hip flexed up 45 degrees. And this tends to show the anterior kind of superior cam deformity the best. So this is kind of a pretty giant cam deformity. This patient has quite a bit of degenerative change, as you can see, osteophyte formation and quite a bit of narrowing here. And then this is not a standing view, so you still see a pretty reliable joint space. But if we took this same patient, took a standing AP, that joint space would.
Can you say what the cam deformity is, like how you can tell that?
Yeah. So basically, we do it based on the alpha angle. And so we draw a circle that kind of best fits the femoral head shape. And we take the degree on the femoral neck for where it starts to fall outside of that circle. And that's called our alpha angle. So a normal hip has, and this is maybe not the best just because it's, like a normal hip has a head to neck junction that has an in cut here. And cam deformity, which again, not necessarily always seen super well in the AP, there starts to be extra bone that forms at the head neck junction. And so when you're flexing up, that extra bone tends to pinch the labrum, and it can delaminate the cartilage, tear the labrum, and cause some of the pain symptoms. So one of the things that, so I think I think one of the biggest misconceptions about labrum tears in general is just oftentimes in the sports world we think, okay, this is an ACL. An ACL tear, that is operative every time, right? And well, almost every time, right? But for most patients, the ACL torn, send to a surgeon, 99% of the time, young, active, they're getting an ACL reconstruction. I think hip labrum tears are a little bit of a different scenario. And we have to start to sort these hip labrum tears into ones that are like degenerative and pointing towards arthritis, the ones that are associated with dysplasia or borderline dysplasia, the ones that are true like FAI labrum tears, and then all of the other pathology that can exist that can be confused with a labrum tear. So I'm going to do a multiple guess answer here. So take an average 30 to 40-year-old patient. If we did an incidence study or a prevalence study of hip labrum tears, and we MRI'd everyone in Utah County ages 30 to 40 that did not have hip pain, so no known hip pain or hip surgery or hip pathology, we took all of those out. So the multiple choice options are, so what percentage hip labrum tears would you find? And your options are 5%, 20%, 40%, or 80%. Those are your options. So again, we're MRIing our radiologists are gonna be super happy to do all these studies. We're MRIing everyone in Utah County, 30s and 40s, that do not have hip pain or have had hip surgery. So everyone thinks they're totally normal. We're doing all this 5, 20, 40, or 80. Okay, who says 5? Raise a hand, 5%. Okay, who says 20? Who says 40? Who says 80? Okay, most of you were right on. It's in between 20 and 40, depending on the study that you looked at. So you were right if you said B or C. I like those kind. I tended to do very well on those kind of tests. Between 20 and 40%. And so our game here is to figure out which labrum tears are really the source of the patient's pain and which maybe existed before the patient had pain and which we can get better, because it's obvious you can exist with a labrum tear and be pain-free. So let's say we get MRI on this patient. She has a labrum tear. What are we doing to try to solve this problem? Like, we don't know if her labrum tear has been there the whole time. We don't know if what are we doing to sort that process out? How can we tell if the anterior pain she's experiencing is really coming from the labrum? Yeah.
Well, I don't know that it says for sure if it's the labrum, but you can tell if it's the joint by doing a diagnostic injection, right?
Mm-hmm.
So putting some numbing medicine in the joint. If the pain goes away, then the pathology is from the joint. Arthritis, that could help too, right?
Sure,
But
yeah.
At least you know this is a hip joint problem and not something else.
Yeah, absolutely. So if our exam fits and our story fits, they have classic signs, we've ruled out kind of borderline dysplasia or dysplasia, and then we have, even if we don't give steroid, we have a diagnostic injection and they say, oh my gosh, 100% of my pain is better, then we know we're barking up the right tree. We've solved the problem of this exists in 20 to 40% of people, but this is truly causing the problem. Yeah, question?
I was thinking in the PT world, we're thinking like muscle imbalance or like super tight in one area, super weak in one other area. If you can create a better balance, you can potentially take away that pain.
Yeah, so what are you doing? So we send this patient to you. Diagnostic injection has worked. We added a little steroid to see if we can, because she's pretty painful. We want to get her through PT. What's your PT approach here?
So we're doing any kind of like fader, favor, just kind of looking at range of motion, seeing what internal external rotation's like. What are those limitations with that?
Yeah.
And looking at certain muscles, looking at the glute medius, what's the ability to stabilize, what's the rotator muscles look like. A differential diagnosis I think a lot of us don't really look at is kind of pelvic floor related. So the obturator internus attaches to the exterior portion of the hip, which could be a differential diagnosis for any kind of lateral hip pain or deep hip pain. So pelvic floor dysfunction could also be there. But a lot of it's the muscle imbalances. So what does internal external rotation strength look like? What's, with a history, like what is their sport, right?
Yeah,
If it's
sure.
a sport, can they do a single leg hop test? Can they stand on one leg? Is there asymmetries? So you're just looking at those imbalances really.
Yeah, absolutely. And what is your treatment approach for the PT in the room? Let's say, you find some muscle imbalances. They maybe also have some lower back stuff. Maybe they're a little stiff through their lumbar spine, which, we know can exacerbate. What's your treatment approach? What are you doing to help this patient? Yeah.
I think the point really is that the injection made them less painful or pain-free. And we say, okay, what are the types of activities or strength positions that you've not been able to achieve because the pain has been limiting you?
Sure.
Right? And so, after 2 years, there's certainly going to be some weakness. So we're going to target whatever muscles we find that are weak, that are creating this imbalance, and say, can we strengthen you in this way to support the hip so it's not moving around? In the absence of arthrokinematic pathology, that's not going to allow them to do that, right? So
Yeah.
we may end up, the pun would be bumping up against the problem here.
Yeah. Well, and that's like the classic, how do you exercise them and strengthen without just causing more pain because you're continuing to irritate? So what are some of your strategies on that front? This is why I like to do a little steroid injection with these patients as an initial treatment approach, because I feel like we help you guys in that endeavor. But what are some of your strategies? Yeah, Scott.
Joint mobilization can be a big help in these people, especially when you do mobilization with movement. So if they've got a restricted internal external rotation, you can provide a distraction force with a little bit of internal external rotation. Improve that joint play and mobility will allow them to move a little bit more freely, so they can then strengthen their mode.
And what are you for hip joint mobilizations? Like, what describe for the group what exactly we're doing?
There's various ways. Often what I'll do is have a patient supine in hook line, and we'll get a mobilization belt. It'll go around their inner thigh and then around my body.
Yeah.
And then I can lean back and pull and get a little distraction to that, and then change the angle of hip flexion, depending on where they're sore, and then kind of work that motion.
So distracting them. So if we're saying, in my little crude model here, if we're saying that this is impinging, your strategy is to distract them and then be able to kind of mobilize and get more motion that way. Yeah, absolutely. Because if the capsule's tight, like if they're limited by the bone, the capsule's going to start to shrink over time, and then everything just becomes more tight. And when everything becomes more tight, it's like driving in a Ford F-350 with an extra spring there, right? You just feel all the little bumps in the road, so to speak. But if your capsule is stretched out, then there's a little bit more, like, I don't know, Lexus, whatever, 430, we have, extra, like we have give there that allows for kind of a smoother ride, so to speak, at the hip. Yeah, absolutely. I saw a hand over here. Yeah, Ashley.
And then you could take those ideas and give them to them with their home exercise program by adding like bands that might attach to a table and have them do certain squatting or lunging movements with the band distracting them. But I'd maybe start with more like foundational movements where they're not squatting, because they're probably afraid of squatting. And
For sure.
It's just going to flare them up. So doing like straight leg hip stability exercises, table exercises, and then putting them into those positions.
Yeah, absolutely. And I think hip stability exercises are critical. Sometimes with my patients, I use the example of an airplane landing. You've all been in a plane where it comes down to the runway and it just slams onto the ground. You would assume at some point that landing gear is going to wear out way faster than if you make a smooth approach. So similar thing when we have more give in the system, or we're more stable, because the bones or the cartilage or the labrum is going to have to absorb the force of your day-to-day activities if the muscles don't. And so our strategy is to strengthen the muscle to put less pressure and tension across the bone, the cartilage, and the labrum, which is what we're trying to preserve. Yeah?
And ultimately, you're trying to figure out, is it a capsular stiffness, like tightness that's happening, or is it a soft tissue restriction? So is the
Yeah.
muscle super tight and guarded around it, or is the capsule super tight? And we treat those differently depending on which one it is.
Yeah. And you could, this patient could have a capsule that was super loose, and this hip's probably not moving. It's arthritic, and so I think that I actually feel like it's a tough call for you guys of when do we call, like we have enough capsular like stretching done, and now we're just aggravating and we're just kind of grinding the cartilage and the labrum every time, and when is it not enough? So like that kind of dynamic for you guys I think is a tough decision. Yeah.
The patient's usually pretty good at telling you.
Yeah. I mean that's
it is right. I love your explanation of the capsule contracting. Right. I always say, you know, it's like your garden gloves that have been in the shed all winter, and you get them out and they're really, really tight and nobody wants to move, and then finally you stretch them out and then things move better, and that's the whole point.
Yeah.
But yeah, usually if they have bony block and you move into that position, it's pretty apparent.
Yeah.
It's not going anywhere.
Yeah, absolutely. Or your doctor takes you off all your blood pressure medication so your hand swells, and then the glove doesn't fit,
Yeah,
right?
same thing, yeah.
Must have quit. All right. Yeah, so absolutely. So what else? So let's say our patient has super awesome physical therapists like all you guys and does really well for a while, and then pain comes back. This is the MRI here. Oh my gosh, showing surgery videos, probably going to talk about surgery. So this is the labrum and the labral tear, and then this is kind of like the socket, or not kind of, it is the socket and the cartilage here. The underneath surface of the labrum here should be continuous with the cartilage. And like when we get into surgery, if you look from underneath, it's kind of hard to tell the junction between the labrum and the cartilage because it's a continuous layer. And so we are out of time already? What? You guys are awesome. Anyway, this is just real quick, like 2-minute surgery video. In order to get into the hip, we have to cut through the capsule. There's like 4 or 5 different ways that we're doing it now, but we're trying to make smaller and smaller capsule cuts and still do the same surgery. So this is labrum here, femoral head, capsule, and then socket up there. And then this is kind of our strategy to fix the labrum. This video is courtesy of Michael J. Salata, so thanks Dr. Salata for this video series. This is a little bit older instrument, but we pass this through the labrum, and then we pull it to the outside and we tie a little stitch. So here's that labrum tearing. I think sometimes patients think when the labrum's torn, it's like ripped in half. But what it really is just peeled off the bone. And so you see a separation from the labrum from the cartilage underneath. So this is passing a suture around, and then because we're really out of time, we'll skip forward. What we want to do is see a good suction seal there. So when the labrum's torn, fluid can pass freely through, and it doesn't provide that stabilizing suction seal. So our goal is to restore that. And oftentimes at the beginning of the case, when I go to pull traction, again, because in order to get in there, just like in order to mobilize the hip, we have to pull a little bit of traction. Sometimes it's super easy, and at the end of the case, after we've fixed the labrum, we try to pull traction, and it does this, pop. And then we want to prevent further, did it play? Well, we want to prevent further impinging, and so often our strategy is to shave the bone down so that as they flex, they're not impinging on that labrum anymore.
When you're fixing the acetate with the labrum, do you scrape the bone to get an inflammatory response? Or if there's scar to it?
Yeah, absolutely. So on the acetabular side, that's a great question. We take a burr and we burr all the way along the course that we're going to fix the labrum. And then that burr that provides 2 functions. 1, it creates an awesome bleeding surface for it to heal. But 2, it creates a flat, stable area for us to put the anchor. And so we use a specialized portal so that our angle, because we're trying to put an anchor here, and the acetabulum is round. We don't want to put an anchor that goes through into the cartilage, so we use kind of a special portal to come at a flatter angle. But yeah, that provides kind of a safe, stable area to put the anchor. We put the anchors across that bleeding surface, pass them through the labrum, tie it down, and then all of that like bleeding when the labrum is there, it heals there. So yeah, great question. All right, any other questions? So I encourage you to look at the x-rays and the imaging. It's hip is so fun, and it's so fun, I think, because it's typically a diagnostic challenge, and it's typically, I think, a little bit tough to help the patients not see. They're used to ACL torn fix, quad tendon torn fix, patellar tendon torn fix, oftentimes shoulder labrum with a dislocation fix, and then hip labrum. They kind of assume every one of them's getting fixed, but we got to sort them into dysplasia with the angles of the hip. We got to sort it into arthritis because the hip tears as it's degenerative, and then we got to sort those ones that have failed PT and are ready for life to be improved. All right, thanks guys.